The trauma wing at 2:17 a.m. had a particular kind of silence, not peaceful, not calm. It was the silence of exhaustion. Monitors chiming at low intervals, suction humming in the background, fluorescent lights buzzing faintly overhead. Rain pressed against the high windows. Every few minutes the ambulance bay doors rattled as wind pushed through the seams. Emily Carter stood at the edge of the nurses' station with a chart balanced in her hands. She had arrived 20 minutes early. No one noticed. That was fine. She had already restocked 2 supply carts that had been left half empty from the previous trauma. She had replaced a cracked oxygen connector in Bay 3. She had relabeled a drawer that held mismatched IV tubing. She did it without announcing the fixes. She did it the way someone repairs a room they expect to fight in later. Across the station, the attending trauma surgeon, Dr. Holloway, flipped through imaging reports with visible impatience. "Where's the new transfer?" he asked, not looking up. Emily stepped forward slightly. "Here, doctor." He glanced at her badge once, then at her hands. "You're the one from Nights in Tacoma?" he asked. "Yes, sir." He nodded slowly, already dismissing her. "Stay out of my trauma bay unless someone asks. We don't need hesitation in there." A few nurses exchanged looks. One of them leaned closer to another and murmured just loud enough to carry. "They say she freezes when it gets loud." Emily heard it. She did not react. Her hands trembled slightly as she clipped her pen to her pocket. She pressed her thumb against the tremor until it steadied. No one saw that part. In Bay 2, a middle-aged man with chest pain was waiting for labs. The medication order had already been entered by a resident. Emily scanned the barcode on the vial before drawing it up. She paused. The dosage was correct for weight, if the allergy profile was wrong. She checked the chart again. The allergy section had been auto-filled from an old visit. It listed penicillin only. But in the scanned intake form, half hidden in the notes, was a handwritten line. "Previous reaction to beta blockers. Severe." The medication in her hand was a beta blocker. She did not call it out across the station. She did not correct the resident in public. She simply walked over, placed the vial beside him quietly, and said in a low voice, "There's an allergy note in the intake addendum. Might want to recheck before pushing." The resident frowned, annoyed at the interruption. He pulled up the chart. His expression shifted. "Oh," he said. Then louder to the room, "Good catch. I was just double-checking." Emily nodded once and returned to the bay. The patient's heart rate steadied 10 minutes later without incident. She did not look toward the nurses who had whispered earlier. She did not need to. Between patients, she walked the corridor slowly, not aimlessly. Her eyes traced the overhead cameras. She noted which crash cart seal had been replaced recently and which had not. She clocked the distance from the trauma bay to the surgical wing doors. She noticed that the exit by radiology stuck slightly before latching fully. When she passed the waiting room television, a news anchor's voice drifted over the speakers. Ongoing search in connection with an armed suspect believed to be in the greater San Diego area. Emily reached for the remote and lowered the volume until it was barely audible. Then she turned the screen off entirely. No one commented. Back in Bay 4, a young woman with a deep forearm laceration was beginning to panic as suturing started. The resident assigned to her fumbled slightly with the lighting. Emily stepped closer, adjusted the overhead lamp by 2 inches, and stabilized the woman's wrist with firm but gentle pressure. "Slow breaths," she said quietly, "in through your nose." The bleeding slowed, the sutures held clean. When the resident tied off the final stitch, he glanced at Emily's hands. They were steady now. At the nurse's station, Dr. Holloway watched the clock and exhaled sharply. "We're too quiet," he muttered. "That means something's coming." As if on cue, the overhead radio cracked with static. "Harbor trauma receiving," the dispatcher's voice said. "Inbound military medevac, single critical, ETA 12 minutes. The room shifted instantly. not loud, not chaotic, but alert. Dr. Holloway straightened. "Get the trauma bay ready. Full team." Emily did not move immediately. She had already checked the airway cart. She had already verified suction pressure. She had already memorized where every instrument lay. She stepped toward Trauma 1 and began laying out additional supplies without being asked. Extra blood tubing, a secondary chest tube kit, a portable ultrasound probe positioned within arm's reach, not across the room. One of the nurses looked at her. "They didn't say chest trauma," she whispered. Emily did not answer. She simply aligned the instruments with precise spacing. Outside, faint but unmistakable, the sound of helicopter blades began to pulse against the rain. The helicopter was audible long before it touched down. The sound began as a distant vibration beneath the rain. Then it deepened, rotor blades cutting through wet air, reverberating against the hospital's upper windows. The trauma team did not speak while they listened. The rhythm of the blades carried urgency without shouting. Emily stood beside the airway cart, eyes lowered, hands resting lightly on the metal rail. She tracked the timing between blade rotations. The wind outside shifted direction twice before the landing stabilized. When the ambulance bay doors opened, cold air and rotor wash swept through the corridor. 2 uniformed security officers stepped aside automatically. The SEAL team entered first. They did not shout. They did not explain. 4 of them surrounded the gurney in a tight formation, moving with controlled speed. Their boots left thin streaks of water across the floor. The casualty in the center was pale beneath soaked bandaging, chest wrapped, abdomen rigid under pressure dressings. Dr. Holloway stepped forward immediately. "Mechanism of injury?" he demanded. "Explosive fragmentation," one of the SEALs replied. "Secondary blast, unknown shrapnel path. Blood loss estimated high." The words were clipped, clean. "Vitals?" the surgeon pressed. "Unstable en route. Hypertensive twice." The gurney locked into place under the trauma lights. Monitors were attached in swift, practiced motion. Hospital protocol began to collide with military urgency almost immediately. "We need paperwork," the charge nurse said automatically. "Later," one of the SEALs answered without looking at her. Dr. Holloway's jaw tightened. "This is my trauma bay. We follow procedure." The team did not argue. They simply stepped back half a pace, but not far enough to disengage. Emily moved in silently to assist with oxygen setup. She did not speak. She adjusted the mask seal with careful pressure, eyes scanning the casualty's chest. There was blood beneath the primary bandage, darker than expected. Dr. Holloway cut through the outer layer quickly. "Entry wound here," he said, indicating a puncture high on the left chest near the clavicle. "Prepare for chest tube." The resident nodded, already reaching for the kit. Emily leaned slightly closer. Her gaze moved not to the obvious wound, but lower, across the sternum along the ribline, toward the flank. The skin tone was uneven, not simple shock pallor. She noted the pulse pressure reading on the monitor, narrowing. She watched the subtle rise of the chest, asymmetrical. The surgeon's focus stayed on the visible trauma. "Collapsed lung likely," he said. "Move." Emily's eyes narrowed almost imperceptibly. The entry wound was small, clean, but the surrounding tissue showed directional bruising inconsistent with straight penetration. She traced the angle in her mind. High entry, downward vector. She looked at the patient's left shoulder. The swelling was wrong for isolated thoracic injury. There was a faint discoloration under the arm, near the axillary line. Not obvious, not dramatic, but there. The SEAL commander's eyelids flickered briefly under sedation. His breathing hitched once. Emily stepped closer to the monitor. Blood pressure dipped again. "Doctor," she said quietly, "the trajectory might not be lateral, could be downward, possible vascular involvement." Dr. Holloway did not look at her. "We'll handle the chest first." "Yes, sir," she replied. But she did not step away. She adjusted the ultrasound probe on the tray and positioned it closer to the surgeon's dominant hand. He ignored it. The resident prepped for the incision. The first cut was clean. Air escaped with a hiss, but not enough to explain the instability. Dr. Holloway frowned. "Pressure still dropping," the resident said. Emily watched the commander's abdomen again. The firmness was increasing. She did not interrupt loudly. She did not escalate in tone. "Doctor," she said once more, measured, "there may be internal bleed below diaphragm." He turned toward her now, irritation visible. "You're not in charge of this bay," he said. "Step back if you can't follow direction." The SEALs watched the exchange without speaking. Emily held his gaze for half a second longer than expected. Then she nodded once and stepped to the side. Her hands remained still. Her eyes did not leave the patient. She repositioned the blood warmer without drawing attention and ensured the secondary IV line was primed. Dr. Holloway continued his intervention. The room tightened around his authority. Emily counted the seconds between blood pressure readings. 5, 4, 3. The commander's skin tone shifted again, subtle but real. She saw it before anyone else did. She said nothing. She waited, because timing mattered more than volume. The room tightened around the surgeon's decision. Dr. Holloway shifted focus from the chest tube and ordered the team to prepare for rapid exploratory surgery centered high in the thoracic cavity. His hands moved quickly, confident. He believed the primary bleed was still above the diaphragm. "Prep for upper thoracotomy," he said. "We control what we can see." The resident repeated the order immediately. Instruments were rearranged, drapes repositioned. Emily felt the shift before she fully processed it. The commander's blood pressure dropped again, not sharply, not dramatically, but steadily. The numbers told a story. 80 systolic, then 76. His skin tone had gone from pale to grey. The chest tube output was less than expected for the instability. That detail mattered. Emily stood at the edge of the field, hands folded lightly at her waist. She watched the angle of the incision being mapped. The surgeon's marker hovered too high. Her mind ran the trajectory again. Entry near clavicle, downward angle. Fragment momentum consistent with blast wave deflection. If the fragment had traveled inferiorly instead of posteriorly, the major vessel risk was not in the chest. It was lower. She felt the familiar tightening in her chest. The quiet calculation, the internal clock. Hierarchy said wait, instinct said move. She hesitated, not out of fear, out of discipline. One sentence. That was all she would allow herself. "Doctor," she said evenly, voice controlled. "Trajectory suggests possible subclavian bypass and abdominal vascular compromise. Ultrasound below diaphragm may confirm." The room did not go silent, but it shifted. Dr. Holloway did not look at her at first. "We've already identified thoracic compromise," he said. "We proceed?" "Yes, sir," she answered. But she did not step away this time. He turned then, irritation sharpening his expression. "You are not running this trauma. Step back." His tone was not loud. It did not need to be. The resident glanced at Emily with something close to relief. Someone else had been corrected. Emily lowered her eyes slightly, as if conceding. Inside, she recalculated. She watched the commander's pulse pressure narrow again. 72. The monitor alarm chirped. "Pressure falling," the resident said. "Push fluids," Holloway ordered. Emily had already increased the rate. The commander's breathing became shallower. Then the drop came. 65 systolic. The oxygen saturation dipped 2 points. The SEALs standing near the doorway stiffened but did not move. They understood what the numbers meant. The surgeon committed to the upper incision. Steel touched skin. Emily saw it clearly now. The angle was wrong. The field of intervention would not reach the true source. The fragment path would have passed beneath the clavicle, deflected downward, possibly nicking a vessel below the diaphragm. If they opened high and stayed high, they would lose time. And time was blood. "Cardiac rhythm unstable," the resident said. The commander's body jerked once under sedation. The monitor tone changed. Flatlining was not immediate, it was worse. It was slow deterioration. Dr. Holloway's hands paused for half a second, just enough to register that something was not aligning. "Why isn't the pressure responding?" he muttered. "Because the bleed is not where you think it is," Emily thought. She stepped forward, not into his space, but into his line of sight. "Fast exam," she said quietly. "Lower quadrant." His jaw tightened. "We don't have time for extra imaging." "We don't have time not to," she answered. It was the only time her voice carried edge. The resident looked between them, uncertain. Another alarm, systolic 60. The room compressed into seconds. Dr. Holloway hesitated. Emily did not wait for full permission. She picked up the ultrasound probe she had positioned earlier and placed it against the lower right quadrant, careful not to contaminate the field. The image flickered onto the screen. Dark. Too dark. Free fluid pooling where it should not be. The resident's breath caught. Dr. Holloway turned his head sharply toward the monitor. There it was. The mistake, not catastrophic incompetence, not ignorance, just assumption. He had followed the obvious wound. The fragment had not. The room changed temperature. The SEAL commander's pulse dropped again. "Abdominal bleed," Emily said. Calm, measured, not triumphant. The surgeon stared at the screen for one long second, then two. Team tension spiked visibly. No one spoke. The resident's hands hovered uncertainly above instruments prepared for the wrong approach. The commander's rhythm destabilized further. Time had narrowed. Dr. Holloway exhaled once, controlled. "Prep for lower access," he ordered abruptly. The shift was quiet, but total. Emily stepped back again immediately, returning to her position near the bloodline. She did not look at the surgeon. She did not claim correction. But she had seen it. She had weighed silence against survival. And she had chosen. The shift in approach did not reset the room. It tightened it. Dr. Holloway redirected the field lower, barking short corrections as the team reoriented. The residents' movements lost their earlier certainty. Instruments clattered softly against the metal tray. Emily had stepped back when ordered. Now she stepped forward again, not loudly, not abruptly. She did not ask permission. She moved to the ventilator. The commander's oxygen saturation hovered in the low 80s. The chest rise was shallow. The previous settings had been calibrated for a thoracic focus. With the field redirected, the physiology changed. She adjusted tidal volume by a fraction, increased PEEP slightly, watched the waveform stabilize. No announcement, just correction. The respiratory therapist glanced at her but said nothing. The numbers crept upward, 84, 87. Small gains, necessary gains. The surgical field deepened. Blood pooled faster than expected. "Pressure still unstable," the resident said. Emily tracked the output from suction. It was heavier now, but something was wrong. The pattern was not linear. There was a lag between visible loss and systemic collapse. Her eyes shifted to the monitor again. Heart rate climbing, pressure narrowing further. Another source, not just abdominal. She stepped closer to the table, staying outside the sterile boundary. "Possible secondary bleed," she said evenly. Dr. Holloway did not look up. "We're addressing the abdominal source." "Yes, sir." She waited half a second. "Trajectory suggests multi-cavity involvement, delayed thoracic seep, or retroperitoneal compromise." The surgeon stopped moving, for one breath. "Based on what?" he asked, not turning. "Blast deflection pattern," she answered. "Entry angle and muscle disruption. It mirrors lateral IED fragmentation." The words were clinical, but they did not belong in a civilian trauma wing. The resident looked at her sharply. "IED." Dr. Holloway turned this time. "You're speculating." "No, sir," she said quietly. "I'm calculating." Her voice did not rise. It did not challenge. It presented. He studied her for a long second, irritation mixed now with something else, uncertainty. "You're a nurse," he said. "Yes, sir. And you're diagnosing fragmentation behavior. I'm recognizing it." The difference hung in the air. The commander's pressure dipped again. 58. The monitor alarm sharpened. Emily did not look at the surgeon now. She looked at the patient. She had seen this pattern before, not in textbooks, in dust, in noise, in places where lighting came from burning metal. "Check posterior thoracic cavity," she said. "Small vessel tear likely. It will not present as primary." Her words were precise, not rushed. Dr. Holloway's jaw tightened. "You are out of line." "Yes, sir." She did not move back. Another alarm. The SEAL commander's hand twitched, reflex, or effort. Emily reached instinctively to stabilize the IV line near his wrist. His fingers brushed her glove, then gripped, weakly, but deliberately. Her eyes dropped to his face. His eyelids fluttered. Sedation held him down, but not entirely. He was fighting upward, his gaze locked on her. Not on the surgeon, not on the resident, on her. Recognition flickered. She felt it like a pulse. He squeezed again, faint but intentional. The room felt it. The resident noticed the contact first. "He's responding." Dr. Holloway glanced down, irritation shifting to confusion. The commander's lips parted. No full words, just a breath that shaped something close to understanding. Emily did not lean closer. She did not speak his name. She only tightened her hold once, steady, grounding. The grip weakened, but it did not release entirely. The surgeon's eyes moved between the patient's hand and Emily's face. "Why would he respond to you?" he asked quietly. Emily did not answer immediately. The monitor spiked again, brief arrhythmia, then correction. "Because I'm familiar," she said at last. "With what?" the resident asked. She held the surgeon's gaze. "With the pattern." It was the only explanation she offered. The surgeon turned back to the field. "Extend access posteriorly," he ordered reluctantly. "Confirm secondary involvement." The resident obeyed. Seconds later, the suction line darkened again. Fresh source, not catastrophic, but enough. Dr. Holloway exhaled once through his nose. "Secondary vessel tear," he said quietly. He did not look at her. He did not apologize. He adjusted. Emily stepped back again, returning to the ventilator. The oxygen stabilized in the low 90s now. The commander's hand slipped from her wrist. Her glove was marked faintly where he had gripped it. The room had gone quieter. No one spoke of rank. No one asked about IED fragmentation, but something had shifted. The surgeon's tone softened almost imperceptibly. "Maintain those vent settings," he said without looking up. "Yes, doctor." The title returned to neutral, but the hierarchy had tilted, not through confrontation, through calculation, through pattern recognition, through a squeeze of a hand that told the room she was not guessing. And for the first time since the helicopter landed, no one laughed. The bleed was controlled for the moment. Suction slowed, pressure inched upward. The ventilator hissed in steady rhythm. The trauma bay did not relax. It recalibrated. Emily stayed at the head of the table, one hand near the airway tubing, the other resting lightly against the commander's shoulder to monitor subtle movement. Her eyes moved from waveform to chest, rise to the pale line of his lips. Sedation had been deepened, but not enough to erase everything. His fingers twitched again. Then his eyelids parted, not fully, just enough. The room noticed. "Easy," the resident muttered. "He's emerging." Dr. Holloway frowned. He shouldn't be. Emily adjusted the sedation drip by a fraction, not to suppress him completely, just to prevent agitation. The commander's gaze shifted. It did not wander, it searched. Past the surgeon, past the lights. It found her. Recognition did not arrive as surprise. It arrived as confirmation. His jaw tightened slightly. Breath moved through the tube in shallow resistance. Emily kept her voice even. "You're stable," she said quietly. "Stay with your breathing." The words were simple, but her tone changed. Not softer, more precise, measured. The commander's eyes sharpened, his lips moved. The first attempt produced nothing but air. The second shaped a sound, a single word, not her name, not the one on her badge, a call sign, low, rough, but unmistakable. The syllables landed like a dropped instrument. The resident blinked. What did he say? Dr. Holloway looked from the patient to Emily. The commander's fingers flexed again, reaching toward her sleeve. Emily did not move closer. She did not move away. She held position. "Sedation's light," she said clinically. "He's reacting to stimuli." The commander forced another breath. His hand rose weakly from the table. Not high, not dramatic, but deliberate. 2 fingers extended, then 3. His wrist trembled. He attempted a salute. Even intubated, even bleeding, even restrained by lines and monitors. The motion was incomplete, but its intention was not. The trauma bay went still. The resident lowered his voice without meaning to. "Is he delirious?" Dr. Holloway did not answer. At the far side of the room, one of the SEAL teammates stiffened. He had been silent since arrival, arms folded tight, eyes tracking every movement. Now his posture changed. He stepped forward once, then stopped. His gaze moved from the commander's hand to Emily's face. Recognition flickered there too. He did not speak immediately. He watched her. Emily felt it. The exposure, the narrowing of anonymity. She shifted her focus back to the ventilator screen. "Maintain sedation depth," she said evenly. "We need him calm." The commander's hand dropped back to the table, but his eyes remained on her, not questioning, certain. The SEAL teammate finally spoke, low and controlled. "Ma'am." The word was deliberate, not casual, not accidental. Dr. Holloway looked between them. "Do you two know each other?" he asked sharply. Emily adjusted the IV line as if it required full concentration. "No, doctor," she replied. The SEAL did not contradict her, but he did not look away. The commander attempted another breath around the tube. A faint sound formed again, her call sign, clearer this time. The resident shook his head. "He's just reaching for something familiar." "Yes," Emily said. That was true. She increased the sedation slightly more, not to silence him, to protect him, and herself. The SEAL teammate stepped closer to the table, careful not to cross sterile lines. "Sir," he said quietly to the commander, "you're secure." The commander's eyes flicked to him briefly, then back to Emily. He relaxed by a fraction. Enough. Dr. Holloway's expression shifted from irritation to calculation. "Why would he attempt a salute to a nurse?" he asked, voice controlled. Emily did not look up. "Patients respond to steady voices," she said. "Sometimes they associate tone with safety." It was a clinical answer. It was not the whole truth. The room absorbed it. The SEAL teammate exhaled once, a breath that held weight. He straightened slightly. "Keep him alive," he said to no one in particular. Emily nodded once. "I will." No performance, no acknowledgement of what had just passed between them. She adjusted the ventilator again, checked capillary refill, confirmed blood products were flowing at correct rate. The commander's vitals stabilized incrementally. The salute attempt had drained him. The recognition had cost him energy he could not spare. It cost her something too. Dr. Holloway cleared his throat. "Focus," he said to the team. "We're not running a ceremony." No one answered. The SEAL teammate stepped back into position against the wall. But his posture had changed. He stood not as a concerned escort. He stood at attention, not visibly, but internally. Emily kept her eyes on the monitors. She did not meet his gaze again. She did not respond to the call sign. She did not acknowledge the attempted salute. Instead, she issued her next instruction calmly. Prepare for repeat hemoglobin check. Monitor pressure trend. Keep suction ready. Her hands were steady. Her voice was level. The authority in the room had shifted again, not through announcement, through recognition, and the cost settled quietly in her chest. Anonymity had cracked, just enough, but she continued working as if nothing had happened, because saving him still mattered more than being seen. The monitor tone shifted first, not dramatically, just a subtle narrowing in the space between beats. Emily saw it before anyone spoke. Systolic pressure dipping again, not fast, persistent. She watched the waveform flatten at the edges, not equipment error, not sedation effect. Internal. Pressure trending down, the resident said late. Dr. Holloway leaned over the field. We've already controlled the primary bleed. Emily's eyes stayed on the chest. The left side was rising less than the right. Not obvious, but measurable. She moved one step closer. Left thoracic expansion is decreasing, she said quietly. The surgeon did not look up. We have a chest tube in place. Yes, Emily replied, but it's not draining what it should. Another beat passed. The suction canister was too clean. The commander's pulse pressure narrowed further. Emily made the calculation quickly. Field memory layered over hospital protocol, delayed hemothorax, secondary pooling, pressure building without visible output. If it continued, the heart would compress. Doctor, she said evenly, we need to reassess tube placement and consider immediate decompression extension. Dr. Holloway stiffened. We are not improvising in my trauma bay. She did not react. Not improvising, she said, correcting trajectory. The resident glanced between them. CT will confirm. He will not make it to CT like this, Emily replied. No heat, no challenge, just fact. The monitor tone thinned again. The commander's oxygen saturation dipped by 2 points. Dr. Holloway's jaw tightened. What exactly are you suggesting? He demanded. Emily met his eyes for the first time since the salute. Reposition and widen access now, she said, before tension escalates. Silence pressed against the fluorescent lights. It was not a request for permission. It was a timeline. The surgeon hesitated. Pride warred with pattern recognition. Another drop in pressure settled it. Fine, he snapped, but I lead. Emily stepped into position without argument. Scalpel, she said calmly. The instrument was placed in her hand automatically. She did not move quickly. She moved precisely. 2 centimeters inferior to the current insertion point, measured angle, controlled depth. She adjusted the existing tube rather than replacing it entirely. Less time, less trauma. Dark blood flowed immediately into suction. Not explosive, but steady. The canister filled in a rhythm that made sense. Output increasing, the resident whispered. Pressure rising, another nurse confirmed. Dr. Holloway watched closely now. Not correcting. Observing. Emily secured the tube with practiced hands, sutures neat, tension balanced. Her breathing did not change. The tremor that appeared when people watched her earlier was gone. Completely. A SEAL teammate stepped forward again, eyes fixed on her movements. He did not interrupt, he did not crowd, but when the suction stabilized and the commander's saturation climbed back 2 points, he spoke quietly. She did that overseas, he said. No one asked him to elaborate. She kept 3 of us breathing with less. The room absorbed it. Dr. Holloway did not respond. He studied the output measurement instead. The commander's heart rate slowed into a more sustainable rhythm. The ventilator waveform widened again. Emily adjusted the settings slightly. Tidal volume increased by a narrow margin, compensating for regained space in the chest cavity. Trend every 2 minutes, she instructed softly. Prepare for transfusion continuation. She did not claim success. She monitored for failure. The resident swallowed. I didn't see that building, he admitted. Emily did not look at him. It was subtle, she said. Which was true. The commander's fingers twitched once more, but weaker this time. Less agitation, more stability. Dr. Holloway stepped back half a pace. "Pressure?" he asked. "Climbing," came the reply. He exhaled slowly. The shift in authority was no longer theoretical, it was procedural. Emily wiped a small streak of blood from the edge of her glove and rechecked the insertion site. Secure, no leak, no air escape, clean. She stepped aside slightly, allowing the surgeon visual confirmation without surrendering control of the monitors. "Continue observation," she said quietly. The SEAL teammate gave a short nod. Respect without display. The commander's saturation reached a safer threshold. Not normal, but survivable. Emily's internal calculation adjusted again. Next risk, clot formation. Next intervention window, narrow. But for now, the bleed was controlled. The room's tension did not evaporate. It restructured. Dr. Holloway cleared his throat. "Document the revision," he said. Emily nodded. No triumph, no acknowledgement of who had been right. Just the next task. She rechecked pulse pressure one more time. Improving. The resident looked at her hands. "They're steady," he said, almost to himself. Emily did not answer, because steady hands were not the point. Correct decisions were. The SEAL teammate moved closer to the commander's head. "He's holding," he murmured. Emily adjusted the IV flow by a fraction. "Keep him warm," she instructed. "We're not finished." But the worst slope had been corrected. The internal bleed no longer spiraled unchecked. And the room understood, without anyone announcing it, that the takeover had not been loud. It had been necessary. Authority had shifted because survival demanded it. And Emily returned to the monitors as if she had never left her place at the edge of the room, invisible again. Except she was not. The suction canister steadied. The chest tube held. Pressure stabilized into something that could survive transport. But Emily did not relax. She watched the commander's neck veins, the color of his lips, the narrowing gap between systolic and diastolic. Bleeding had been the first problem. Clotting would be the second. Massive transfusion shifted chemistry fast, too fast, and the body tried to correct in ways that killed. "Coag panel?" she asked quietly. The resident scanned the screen. "Pending." "Trend lactate," she said, "already rising." The monitor showed a brief irregular rhythm, premature contraction, then another, subtle, but pattern forming. "Clot risk," Emily said evenly. Dr. Holloway straightened. "We just controlled hemorrhage. We are not thinning him now." "I'm not suggesting thinning," she replied. "I'm suggesting controlled balance." The surgeon's expression hardened. "You don't run anticoagulation strategy in my OR." She did not react. The labs populated, platelets low, coagulation factors strained. The body was shifting from bleed to block. Microclots could form where they were not wanted. Lungs, brain. The commander's oxygen dipped again by a narrow margin. "Look at waveform variability," Emily said quietly. Dr. Holloway did. He saw it now, not obvious, but real. The SEAL teammate stepped closer. "What's happening?" "His blood is trying to protect him," Emily answered, "but it may overcorrect." The surgeon exhaled sharply. "This is textbook trauma response. It's also a battlefield pattern," she said. That word changed the air. Battlefield. Dr. Holloway's pride stiffened. "We are not in a war zone." "No," Emily agreed softly, "but his physiology is." Silence. She moved to the medication cart. "Balanced factor support," she said. "Measured, not aggressive." "That protocol isn't standard here," the resident muttered. "It is standard where he was treated before he got here," she replied. Dr. Holloway studied her face. "You're asking for a military-grade coagulation sequence," he said. "Yes." Hospital administration entered the bay at the worst possible moment. 2 suits, tight faces. "What is happening?" one demanded. Dr. Holloway spoke first. We are managing complications. The administrator looked at Emily. Why is she directing? Emily did not answer. She adjusted infusion rates with controlled precision. Her credentials do not include surgical authority, the administrator continued. Emily ignored him. Vitals were shifting again. The commander's heart rhythm stuttered, then paused. Flatline, for half a second, then another. Pulse lost, the resident whispered. The room froze, not from chaos, from recognition. The line extended, clean, straight. Start compressions, Dr. Holloway ordered. Emily moved first, hands positioned perfectly, not frantic, measured depth, correct rhythm. She counted quietly under her breath. Internal timing. 2 minutes. Airway maintained. Epinephrine prepared. But she saw something deeper. The clot risk had tipped into obstruction. She felt it in the resistance of compressions. Not collapse. Pressure. Doctor, she said evenly while continuing compressions, we need targeted reversal, now. The surgeon hesitated. That hesitation cost seconds. The monitor remained flat. The SEAL teammate's jaw tightened, but he did not interfere. Do it, Dr. Holloway finally said. Emily stepped aside only long enough to administer the sequence she had requested. Measured dosing, calculated risk, not reckless. Focused. The administrator tried to speak again. The SEAL teammate blocked him without touching him. The medication entered. The seconds stretched. Emily resumed compressions. Her arms did not shake. Her breathing stayed controlled. Inside, the weight pressed hard against her ribs. Not fear, memory. She had felt this silence before, in sand, in dust, in rooms where air tasted metallic. She pushed the thought away. Come on, the resident whispered. The monitor flickered, one beat, irregular, then another, weak but present. Pulse, someone breathed. Emily slowed compressions gradually, hands hovering, ready. The rhythm strengthened, still unstable but alive. Dr. Holloway stepped forward, eyes locked on the screen. He's back, he said quietly. No one cheered. They watched. The waveform smoothed into fragile continuity. Emily adjusted oxygen again, reduced infusions slightly, balanced, always balance. The administrator stood silent now. The pride in the room had nowhere to land. Dr. Holloway looked at Emily. No hostility left, only acknowledgement. That protocol, he said carefully, is not in our manual. No, she replied. She did not elaborate. The SEAL teammate leaned close to the commander's ear. You're still here, he murmured. Emily stepped back half a pace. Her hands began to tremble. Not during the crisis. After, always after. She folded them behind her back so no one would see. Her breathing remained steady. Inside, something heavier shifted. Every save carried cost, not visible on monitors, not charted in notes. The administrator cleared his throat softly. Document everything, he said. Emily nodded. She returned to the charting station without ceremony. Vitals stable, for now. Clot risk controlled, bleed contained. The surgeon spoke quietly behind her. You were right. She did not turn. I was responsible, she said. The commander's pulse steadied into a sustainable rhythm. The crisis passed its sharpest edge, and Emily stood again at the edge of the room. Invisible. Except everyone had seen what mattered, and the cost lingered quietly behind her eyes, where no one documented it. The monitor did not alarm. It thinned. Pressure began to drift again, subtle, steady. Not catastrophic. Worse. The kind of decline that hides until it is too late. Dr. Holloway watched the arterial line. Prep for OR, he said. No argument, no ego, just urgency. The transfer team moved fast, controlled. The commander's chest tube remained secured. Blood warmed, lines checked. Emily's eyes stayed on the waveform. There, a pattern. Not bleeding, not clot. Mechanical. She stepped beside the gurney as they rolled. His left lung compliance is dropping, she said quietly. The anesthesiologist glanced at the ventilator screen. Settings are stable. Compliance isn't, she replied. No challenge in her tone. Just data. They entered the operating room under harsh surgical light. The storm outside rattled the windows faintly. Inside, everything narrowed to sterile green and white. Time, the circulating nurse called. No one hesitated. Dr. Holloway moved to the table. He did not look at Emily, but he did not tell her to leave. That was the difference. Incision reopened. Suction steady, blood controlled, the thoracic cavity exposed, the pressure drop deepened. Emily stepped closer to the ventilator. She adjusted tidal volume carefully, not drastic, measured. The anesthesiologist watched her hands. Explain, he said quietly. Air trapping, she answered. Micro-obstruction, not enough escape. He nodded once, adjusted with her. The commander's pressure dipped further. Dr. Holloway leaned into the field. I don't see active hemorrhage, he said. Emily's eyes scanned the cavity, not for what was obvious, for what was wrong with the pattern, the injury trajectory from earlier, combat pattern, secondary tissue swelling, hidden pressure. Pericardial tension, she said softly. The room stilled. Dr. Holloway froze. Show me. She did not touch the surgical field. She indicated with 2 fingers, precise, controlled. There, subtle bulge, constrained space, not obvious unless you knew to look for it. Dr. Holloway exhaled slowly. You're right. He did not argue. He did not question credentials. He moved. Careful incision, controlled release. A dark, sudden surge. Suction engaged instantly. Pressure line jumped, not high but alive. Emily adjusted ventilation again. Balanced oxygen, balanced volume. No overcorrection. Pressure rising, the anesthesiologist said. The waveform thickened. Heart rhythm steadied. The SEAL teammate stood rigid at the far wall, eyes locked. No one spoke beyond what was necessary. Emily monitored perfusion to the fingertips. Color improving, capillary refill returning. Dr. Holloway repaired with focused efficiency. No wasted motion, no pride left in the room, only precision. Hold pressure, he said. Emily positioned hands exactly where needed, not dramatic, not showy, her touch firm and stable. The surgeon sutured, the tension eased. Minute by minute, the commander's vitals rebuilt themselves, weak but sustainable. No one cheered, no one exhaled loudly. They watched the monitors as if afraid to disturb the balance. The arterial line stabilized within safe range. Oxygen saturation climbed 2 points, then 3. The anesthesiologist nodded slightly. He's holding. Dr. Holloway stepped back. For the first time that night, he looked directly at Emily. Not over her, not through her, at her. You saw it before I did, he said. She did not answer. She returned to the ventilator settings. Fine adjustments, always fine adjustments. Authority in the room had shifted without announcement. Dr. Holloway did not give orders to her. He asked, anything else? She scanned the field once more. Watch for rebound swelling, she said. Slow rewarm. He nodded. The circulating nurse recorded vitals. The rhythm steady now. Not perfect, but stable. The storm outside lessened, rain soft against glass. Inside, the silence thickened. The kind that follows crisis when everyone understands how close it was. The SEAL teammate stepped forward cautiously. He going to make it? He asked. Dr. Holloway glanced at Emily before answering. He has a chance. Emily checked the monitor one last time. The numbers held. She stepped back from the table. Her hands were steady. No tremor now. Not from observation, not from pressure. The reversal had happened quietly, not with speeches, not with humiliation, through competence. Dr. Holloway removed his gloves. You lead the sequence, he said. It was not an apology. It was acknowledgement. Emily only nodded once. The commander's chest rose evenly under mechanical rhythm, color returning slowly to his face. He was not safe, but he was alive. The OR lights remained bright. The staff began cleanup in controlled silence. Emily removed her gloves last. Inside her chest, the weight pressed again. Not pride, responsibility, authority had shifted, but she did not reach for it. She stepped back into shadow, letting the monitors speak. And the room understood, not who she was, but what she was capable of. And that was enough. The operating room emptied slowly, not with relief, with exhaustion. Metal trays clinked softly. Gauze counted, instruments logged. The storm outside had faded to steady rain. Emily removed her cap and mask without ceremony. Her face looked the same as it had before the helicopter arrived, calm, unreadable. In the hallway outside recovery, 2 SEALs waited. They stood differently than the rest of the hospital staff. Still, balanced, watching doors instead of screens. When Emily stepped through, they straightened. The taller one spoke first. "Ma'am." Not loud, not dramatic, just precise. She shook her head once. "He's stable, for now." The second SEAL nodded. "We know." There was no applause, no handshake extended too far. The first SEAL placed his fist lightly over his chest, a gesture used rarely, reserved. "Thank you," he said, not for the room to hear, for her. Emily did not step into the gratitude. She adjusted her gloves. "Keep him warm. Watch his output closely." It sounded clinical. It was intentional. Dr. Holloway approached a moment later. His surgical gown was gone, his posture different. He stopped a few feet from her. "I reviewed the trajectory again," he said quietly. "You were correct about the secondary pressure." He did not add anything more. No apology, but the acknowledgement cost him something. Emily inclined her head slightly. It was visible. He held her gaze for a second longer than before. "I should have listened sooner." There it was, clean, unadorned. She did not ease his discomfort. She did not sharpen it. "We were both watching the patient," she replied. That was all. Down the hall, hospital administration gathered in tight formation. Whispers, phones, emails already forming. Someone had accessed her personnel file. Someone else had found gaps. Transfers that did not explain themselves, letters of commendation that were sealed. A deputy administrator approached with a tight smile. "Ms. Carter, we need to review your credentials. There were irregularities." Her tone was not hostile, just cautious. Emily met her eyes evenly. "My license is active. My certifications are current." "That may not be the issue." A man in a dark suit stepped forward from behind them. He carried no badge outwardly visible, but the way security parted made his position clear. "I believe it is sufficient," he said calmly. He extended a slim identification wallet, just long enough for the administrator to read. The color drained from her face slightly. "Of course," she said quickly. The man turned to Emily. "We were not aware you were on civilian rotation here." She did not answer that. He studied her a moment longer. "Your service record speaks for itself." She looked past him toward recovery. "Is he conscious?" "Briefly. He asked for you." She hesitated only once, then nodded. In the recovery unit, the SEAL commander lay pale but stable, oxygen steady, lines secure. His eyes opened as she approached. He was weaker now, but aware. He did not smile. He did not speak loudly. He lifted his hand slowly, deliberate, controlled. The salute was not perfect. His arm trembled halfway up. But it was real. Emily stood still. For a fraction of a second, the past pressed against the present. Then she lowered her gaze slightly and returned the smallest nod. No salute back. Not here, not in a civilian hospital at 3:48 a.m. "You kept your hands steady," he said quietly. "You kept breathing," she replied. That was their exchange, nothing more. Outside the room, the military liaison waited. "Command will want to formally recognize your intervention." "No," she said. He paused. "It would be appropriate." It would not help him. Her voice did not harden. It settled. He studied her expression and understood. Very well. Back at the nurse's station, word had spread. The whispers had changed tone, not mocking, measured. Dr. Holloway passed by her once more. "There will be a debrief," he said. "I'll attend," she replied, "not as a subordinate." She met his eyes again. "I'll attend as a nurse." He gave the faintest nod. The night thinned toward morning. Paperwork began, forms printed, reports drafted carefully. Emily stepped into the locker room before anyone could gather a crowd. She changed quietly, folded her scrubs, washed her hands slowly. In the hallway, someone mentioned a possible press inquiry. Another suggested a hospital statement. She moved toward the exit instead. No ceremony assembled, no cameras. Behind her, the SEAL team remained near recovery. One of them watched her walk down the corridor, not with curiosity, with recognition. She did not look back. The fluorescent lights hummed overhead. The storm had almost stopped. Her footsteps were even, measured. She reached the side exit before dawn fully broke. No applause followed her, no announcement, only the quiet understanding that the room had changed, and she had already stepped out of it. Morning did not arrive all at once. It edged in. Grey light pressed through the high windows of the trauma wing. The storm had weakened to mist. The hospital shifted from night tension to day noise, clipboards, coffee cups, fresh voices replacing the ones that had carried the night. Emily was already moving, not toward recovery, not toward administration, toward the supply room. She lifted a box of saline from the lower shelf and stacked it with the others, checked expiration dates, replaced a torn suction catheter wrapper, realigned a crash cart drawer that had been closed too fast hours earlier. Her hands were steady again. The tremor had never been fear. It had been restraint. 2 day-shift nurses entered, whispering. They went quiet when they saw her. One of them cleared her throat. "We heard about last night." Emily sealed a package of sterile gauze and placed it back in the bin. "Room 3 needs a fresh tubing set." It was not dismissal. It was direction. They nodded and left. Down the corridor, Dr. Holloway stood near the charting station longer than necessary. He had removed his white coat. For the first time since she met him, he looked less armored. He approached her slowly. "Emily." She turned slightly. "Yes, doctor." The title was clean, neutral. "I reviewed the operative summary this morning," he said. "Your intervention changed the trajectory." She did not answer. He continued. "I was wrong to dismiss you." There was no one else within earshot, no audience, no need for volume. Emily adjusted a tray of sutures. "The patient is stable," she said. "That isn't what I meant." She looked at him fully now, calm, direct. "I know." A silence settled between them. He searched for something more to offer, an apology that carried weight, recognition that might repair hierarchy. She spared him the struggle. "We were working toward the same goal," she said. He lived. The surgeon studied her a moment longer. Respect now lived where irritation had once been. "If you ever choose to lead a trauma rotation," he said quietly, "you would have my support." Emily nodded once. Then she returned to inventory. The conversation ended without ceremony. Outside the hospital, a black SUV idled briefly near the ambulance entrance. The SEAL team exited in formation. No press waited, no crowd gathered. The commander, now upright but supported, paused before entering the vehicle. He looked back toward the building, not searching for applause, searching for confirmation. Through the glass doors, Emily crossed the hallway carrying a tray. She did not see him, or perhaps she chose not to. He raised his hand once in acknowledgement, small, private, then lowered it and stepped into the vehicle. The SUV pulled away. By mid-morning, a hospital memo circulated, clinical summary only. No names attached to decisive moments. No mention of who altered the intervention path. The event was described as collaborative trauma management. Emily read the memo once, then archived it in her inbox. She did not correct it. She did not forward it. Recognition diluted on paper meant the patient's privacy remained intact. That mattered more. Near noon, the news broadcast mentioned a military officer recovering from emergency surgery at a local facility. No nurse was named, no conflict described, just weather, traffic, and routine headlines. Emily stood at the sink outside Bay 4. A pediatric patient needed a bandage change. She washed her hands slowly. Soap, water, rinse, dry. Her movements were identical to the night before. No hesitation, no triumph. Inside the locker room, her old insignia tag rested at the bottom of her bag. She did not take it out. Not today, perhaps not again. The night shift schedule was posted for the coming week. Her name remained in its place. No promotions, no new title, just Emily Carter, RN. She reviewed the assignment board. 2 trauma holds, 1 observation case, routine, predictable, earned. As afternoon light replaced the grey of dawn, the hospital resumed its steady rhythm. Monitors beeped, wheels rolled, voices overlapped. Emily moved through it all without announcement. A junior nurse approached her near the medication station. "Can you double-check this dosage?" the nurse asked quietly. Emily examined the vial, calculated in her head, confirmed the adjustment with a soft nod. "Good catch," the junior nurse said. Emily returned the vial. "Always verify. No lecture, no performance, just precision." As her shift ended, she walked the same corridor she had walked 100 times. The same fluorescent hum, the same scuffed tile. People she passed no longer laughed. They did not salute either. They simply stepped aside, not out of fear, out of respect they did not yet have language for. At the exit, rain tapped lightly against the glass. The storm had passed. Emily paused only long enough to check her watch. Then she stepped into the cool morning air. No cameras followed. No ceremony awaited. Behind her, the hospital continued, lives stabilized, mistakes corrected, egos quieter. She walked toward the parking lot with measured steps, invisible to most, unforgettable to the few who had seen her hands in motion. No spotlight found her. She did not look for one. The weight she carried was not glory, it was responsibility, and she carried it without display, calm, heavy, earned.